using any kind of MRD in these T-cell lymphomas, and where would you find that to be potentially? Can we use that to identify people who are heading for trouble and maybe transplant them before they get into trouble, or do some other novel approach?
Sure. That's a billion-dollar question. We don't have anything that's currently sort of proven to be a right technology for the MRD. There's a couple of trials that are ongoing. Well, first of all, how do you define MRD? So one of them is the TCR receptor. You could look at that in that particular individual. It's difficult to do that because every patient is different. You would have to make primers for each specific patient. The Alliance trial, which is ongoing currently, which is a 3-arm study of upfront treatment in CD30 negative T-cell lymphomas. It's CHOP plus Duvi, CHOP plus 5-AZA, and CHOP by itself or CHOEP. They are looking at MRD in those patients. They're working with Stanford, Dr. Alizadeh, he has a technology to look at that. And I think there's this study out of Mass General that's also trying to look at MRD in the stem cell aliquot of before the transplant to see if we can. So we're very early in this field, really, to try to figure that out, because I think that would really make a difference. Because if you could see who had MRD positivity, just like you did in mantle cell or other B-cell lymphomas, I think that would make a big difference, and you would know how to approach those patients. Unfortunately, we're not there yet. We do have some molecular data, like P53 mutations have a poor prognosis. So those patients probably, if you have that mutation, even if they achieve a remission, probably should go to an allo transplant rather than an auto transplant. Then in ALCL, we have certain data, ALK-negative ALCL, where the presence of DUSP22 translocation is positive, but if you have a P63 mutation that drives P53, those patients do poorly, and so maybe should not be offered an auto transplant. So we have some data to select out patients of auto versus allo, but not a great, I mean, I couldn't hang my head on anything at the moment.
Dr. Iyer, looks like you have something to add.
No, I totally agree with Dr.
Who I
Zain.
didn't properly introduce is Dr. Swami Iyer from MD Anderson, and I also didn't properly introduce Dr. Sica from Montefiore and Albert Einstein. So, sorry.
Thank you. Thank you for the invitation. I think it's great to be here and to sort of brainstorm about these issues. It's especially T-cell lymphoma. I mean, Jasmine and I and Alec, we talk about our patients all the time, 2 times a week. But one of the corollaries, I totally agree with her, is that somebody gets an auto transplant, goes into remission, and then they do a bone marrow, and they send out, and the bone marrow is normal, and the next thing you see is the TCR is positive. That's not disease. So that's often a scenario that comes up. And the problem is the TCR testing that is done is not, it might be sensitive, but it's not specific. And you have clones floating around. If you look at AITL patients, you have clones of T cells that are floating around at all times. So I think we've still not defined. I think you started with the least controversial topic in T-cell lymphoma.
Well, there is potentially more specific MRD test, just like how we use clonoSEQ in B-cell. There's a clonoSEQ T-cell assay that you, in theory, could tease out the specific lymphoma-associated sequence and not be looking at those other clones. Is that any more useful?
The folks from China have started doing it, but I think it's very early.
Very early. We don't have prospective data to collaborate.
In the setting of EBV-associated lymphoma, I think that might be a useful marker, particularly NK T-cell lymphomas and certain T-cell lymphomas.
So maybe I'll ask Dr. Sica a question here. Dr. Zain presented some interesting data. I think it was the PETAL study that showed outcomes based on single agents versus conventional chemo and based on whether they got transplant. So in practice, what comes up a lot is you have a very sick patient in the hospital who's relapsed with a PTCL, NOS, let's say, and rapidly progressive disease, highly symptomatic. They need treatment in the hospital like today. Are you not giving conventional chemotherapy to a patient like that, or is that our only option until we can get something else approved outpatient?
Yeah, so thank you for inviting me. Thank you for all of this very informative session. So in general, many of these agents are not available or are very difficult to get. If you have a patient in the hospital with acute relapse, we need to stabilize them. We, unfortunately, the best we have, we still use chemotherapy to stabilize them and then to proceed into a autologous transplant if we can. We, on occasion, have used pralatrexate or duvelisib in some patients. It takes a long time to get approvals, but we eventually have done it. We have had very good responses, but again, those are anecdotal. We do not have like enough data to use those agents instead of using conventional. So unfortunately, most of the time we end up using chemotherapy and transplant if we can.
So that type of a patient, you give like just a conventional platinum-based second-line chemo in the hospital?
Yes, we use ICE mainly, sometimes use DHAP or GEMOX. If they respond to that and they did not have an autologous transplant, we would then proceed to an autologous transplant.
In the relapse setting, auto or allo?
If they relapse after an auto and we can induce again, we go for an allogeneic transplant.
So let's say a patient like we just talked about is responding to this platinum-based regimen, they get out of the hospital. Do you continue that regimen, or do you try to get them a single agent based on that data? You don't want to take the chance because they're responding, right?
Well,
Anybody can respond to that.
why mess with something that's worse?
Exactly.
Because of that data that you just showed us.
Yeah, I mean, I think most of the time what we find is that that's sort of like the starting point, and they will eventually get resistant to it, right? So the way I look at ICE is you can't give 5 cycles or 8 cycles of ICE, I mean, in 1 or 2, and then if the transplant's not ready, then you have to switch to something else. I don't know what your experience is, yeah.
Yeah, I totally agree with that. One thing about the chemotherapy, if you go back to the Oracle study, what you can learn, I mean, 2 things you can learn. One is that AZA is a good agent, but the study has to be designed properly. If the PFS was not 12 months, and if it was 5 months, I think it would have been a winner. Second is those patients who received chemotherapy.
It looked like a positive study to me, almost.
Yeah, overall survival, yes, but that is the secondary endpoint, though. The primary endpoint was not met. The second is the chemotherapy. If the patients get chemotherapy, the median PFS was 2 months. Why? Because they didn't go to transplant. So to the point that Alex was making, if somebody didn't get an upfront transplant, I think that may be an opportunity to convert a chemosensitive disease into high-dose therapy. But in lieu of that, I think the only thing you have is clinical studies. And that's where a scenario where you might use a single agent, look at targets like CD30, that's the lowest hanging fruit. But I think if you, in those situations, I think they should be always considered for an allo transplant.
So Dr. Oh, you have something to say?
I think that I'm going to use again your presentation first, Tim. In large cell lymphoma B cell type, you get 2 shots. I think in this disease you have 1 shot. And I think the big controversy in my clinic is when you get a patient young, let's say 30s, 40s, in CR1, should we go really for more aggressive than just an auto in that case? I mean, those patients are potentially curable with an allo transplant, and it's totally underutilized now. Keep in mind, obviously, the risk of GVHD and all of those to keep in mind. But now with new regimens, we certainly have a better probability of controlling GVHD, of trying to prevent it, and so on. So I think that allo transplant in the younger patient is totally underutilized, and it's a therapy that certainly is effective. I think even auto transplant in frontline consolidation is not as utilized as it should be. And many of these patients achieve CR, and they are monitored in the community without any type of intervention. The other challenge, as Dr. Jasmine mentioned, is really that these diseases have always been lumped in a group. And you can look at AITL, it's a totally different disease, even though we tend to look at them as mature lymphoma. So I think the only option we have to really advance this disease is to try to dissect it similar to what we did with ATLL. You know, look at the genomic profile of those patients, look at what can be targeted. They are very prone to immunosuppression, they are very prone to hypomethylating agents, and so on and so forth. So I think that CHOEP and CHOP, and the reality is they are not effective, and we need to move past that. And we seem to be stuck in that at this point.
Yeah, actually, when I was at MCW with Mehdi and Narav Shah, we kind of had a powwow, and we have another partner, Walt Longo, who'd been doing transplant for decades, about what to do with AITL, and our sort of collective experience was that when they relapse, it's very difficult to get them to transplant. And to your point about having one shot, we just kind of decided as a group that we were just going to allotransplant all the eligible patients in first remission because there is a pretty robust graft versus lymphoma effect there. And so, I mean, so far, the ones that we did, it worked out pretty well, but every so often it will, you know, bite you. But are there any other patients for the whole panel that you would strongly consider an allotransplant in first remission?
Yeah, all the like gamma delta T cell lymphomas, hepatosplenic T cell lymphomas,
Hepatosplenic. Yeah.
ATLL. I mean, you can barely get them into remission.
Right,
if you
those
can.
are tough, yeah.
And the only survivors, at least that I have, are the ones who had an allotransplant. And then cutaneous T cell lymphomas is a whole other disease, and you know, eventually the only curative therapy there, quote unquote, is still an allotransplant.
Which entity? Sorry, I didn't hear.
Cutaneous T cell lymphoma.
Oh,
mycosis
yeah.
fungoides. Yeah, I didn't even go there. But yeah, so some subtypes, the rare subtypes you have. I think for EDL, there's still data that auto transplant is effective. You can get them into remission, but others, it's mostly allo.
I saw some data. Oh, we have a question from the. Yeah,
Sorry,
I should be better about checking the audience. Sorry.
No, I just wanted to go back to what Mohamed said about, you know, CHOP and CHOEP not being effective. And, you know, as a junior staff, I've always just assumed, I don't know if this is what happened, but I assumed that they took what worked in B-cell lymphomas and said, well, let's just do it for T-cell lymphomas. So one, should we be questioning the backbone that we're using instead of just adding to that backbone? And are there any, you know, future moves to try to change that backbone?
Right, so we've gone back and forth on that in the T-cell community. That's a very valid question, and it's really been discussed a lot, and then eventually we come back to it because we haven't found anything. There was a PEGS regimen, which was etoposide, gemcitabine, and steroid, didn't really show any improvement. I did a study with lenalidomide and romidepsin in older patients, and even though we had good responses, it wasn't robust. I mean, CHOP will still give you a good initial response. It's just not sustained. So that's the problem. So we've talked about it. I think once this data matures, the randomized trials that are doing, maybe we can start thinking about combinations in the upfront setting.
Oh, Maddie has a question.
It's my question is mostly for my learning, right? I'm not a T-cell expert. I struggle with those patients. And I'm just gonna, instead of reading, I'm gonna be lazy. I'm sitting on 3 patients right now. So I'm gonna ask 3 people about my 3 patients. So one question for Dr. Iyer. Once a year, we get a monomorphic epitheliotropic T-cell lymphoma in MCW. And for whatever reason, it's my luck, it always comes to my clinic. So I have a couple of survivors that I allografted up front. But the 3 other patients I saw, they tend to perf. When they perf, they're sort of like no salvaging those patients. So the question for Swami is like, if you see a metal patient, what's your go-to induction regimen, and do you think about an allograft for those patients? Second question I'm gonna just ask them in a go, right? So second question is for Jasmine. NK T cells, like when they're limited stage, Tim taught me over the years that they do really well with combined modality therapy. We leave them alone. But advanced stage NK T cell lymphoma, like I tend to think about allograft in those patients. If we get them in remission, is that still contemporary practice? And finally, in Wisconsin, for Dr. Sica, we don't see adult T cell leukemia lymphoma patients. And again, my luck, when we see them, it ends up in my clinic. So I tend to think that generally the lymphoma version or the aggressive leukemia version, you allograft them up front. But if you don't do that, I'm sitting on a patient who was seen in community, was given CHOP, of course he relapsed. Then they gave him hyper-CVAD, of course he relapsed. And now he's sitting in my clinic, like what would be your go-to regimen for that patient to get him into remission? And then the patient also has very high HTLV viremia right now. Is that something that gets controlled when you treat those patients, or would you go for an antiviral in that setting? So sorry about like a long-winded 3-part question.
No, a good question.
The EATL case.
The metal.
Oh,
needle.
Yeah.
So yeah, I think the needle and needle split in after 2007. It's called type 2 And the type 1s are treated differently, and there is some sensitivity. They all have CD30 expression. At least you have brentuximab as a choice. Metal is very different. They fall along the gamma delta category. They have JAK-STAT mutations or the pathways. Sometimes they have the SETD2, just like hepatosplenic gamma delta T cell lymphomas. The default, like you said, is CHOP. But I don't think it's a very good regimen. Most patients perf. Historically, what used to happen for metal and needle is that they perfed, went to a surgeon, they debulked, and the chemo was given. So they actually had a better outcome in that situation. But today, most surgeons do not want to touch somebody unless it's a colonic mass and they think it's possibly adenocarcinoma. They go and find that this is metal. But if it's an intestinal mass, unless it's bulky, they don't do that, or if there's a perforation. So outcomes have been poor if they don't go through this pathway because they don't have a bypass. And most patients who get CHOP who don't have a surgical outlet don't do as well. You have occasional patients who do well. So your choice is right now CHOP, but what we have done is to add agents to it. Anecdotes. These anecdotes, no studies, I don't think you can do a study. We had a patient with pegasparagine and CHOP, another patient with Jakafi and CHOP. And we had another older lady who didn't respond to anything. We just gave budesonide and Jakafi. So, and one of the things that's also clear in metal is it's not just the bulk of the mass, it's also microscopic disease in the intestine that you don't always see. And so what do you do for those patients? And in those situations, you give something that works. But I agree with you that once they do get into remission, you also have to not just do a PET scan, but also do an endoscopy before and after treatment, and then take them to an allo transplant if possible. But again, the median age is higher, and you have young patients, so there's bimodal. There's younger patients, and also the older patients. Younger patients, I think an allo is the best approach.
I forgot the second case already. Hopefully you remember.
So the NK T cell issue. So yes, limited versus advanced stage disease. So advanced stage disease, I always, try to get them salvage therapy. So it's, it comes with stage 3 or 4. You start with SMILE or one of those regimens that has pegasparagine in it if they can tolerate it. There's now a lot of studies with upfront checkpoint inhibitor combinations as well. And then an allo transplant. I think there is some data for auto transplant in that setting as well, but I always found that allo is, eventually they're going to need that anyway. So.
The last case was the ATLL?
HTLV1.
So for ATLL, we have the Shimoyama classification, the acute and the lymphomatous. For the leukemic ones, we did not have a lot of luck with chemotherapy and many people. So the best answer would be clinical trial, and most of the time we consult, thanks to Dr. Iyer and Dr. Zain and many of other my colleagues. If it is an acute form, I'm using in PEG interferon, Biktarvy, and venetoclax, and I was able to achieve complete responses. The antiviral issue is controversial. I do use Biktarvy because it's a newer generation antiretroviral, and we have experimental data that works. So if they have chemotherapy, I have several cases with acute forms that they responded to interferon, Biktarvy, and venetoclax. And then, of course, they need to have immediately an allogeneic transplant. The lymphomatous forms, typically we treat them up front with EPOC. In our future trial, we're also adding interferon and Biktarvy to stimulate the immune response. But what I do many times is radiation therapy works really well as part of the bulking and also as part of conditioning. And the transplant or cellular therapy, whatever we use, tends to work much better in those circumstances.
I would say that the other controversy there for the allotransplant is really what's the best regimen for them. No randomized data, obviously, but I think the data from Japan have shown that, I think it's a joint Japanese-Korean study that showed that melphalan-based regimens do better than busulfan-based regimens. Again, not prospective, but certain to keep. And the important factor to keep in mind is that the survival in CR1 is probably around 35–40%, but in CR2, if you don't do it, it's less than 5% or 10%. So even in CR2, you may get a little bit impressed by that CR2, but the long-term outcomes are not good. So the best is to transplant those patients in CR1 with hopefully a melphalan-based conditioning regimen.
So Oh.
For your ATLL patient, maybe you should consider the valometastat study or the CTX-131 with Alex.
I was going to ask the group, nowadays when people get newly diagnosed with a heme malignancy, they get this, NGS panels sent off, and is there, and it may be useful in practice or not, but do you routinely send off an NGS panel at diagnosis or on relapse, and how specifically does that information help you in treatment selection?
So we do. I see the son of Dr. Logavi here. So most of the time we get cases in the sinus, and you don't know whether it's a T cell or NK T cell.
Or
sometimes,
just for any T cell lymphoma, I mean.
True.
Yeah.
So there are specific case scenarios. AITL, I think to differentiate between the subtype, I think it's helpful. There are the PTCL, the T follicular helper phenotype that may look very insipid and may end up being called as a PTCL NOS outside, and then you do the NGS, it actually has an epigenetic mutation, so you'd rather put them towards demethylating agent or histone deacetylase inhibitor. So in general, I think we do it because we collect data, but I think the utility is probably not as much as you see in other lymphomas.
Are there specific mutations that would change your approach either?
I just changed institutions, and there's no standard, so MSK has its own impact. It's a panel. So I think one of the things I look for it more in the relapse setting to see if there's a JAK-STAT pathways that are mutated, or if there's an IDH2 mutation where we know that the 5-ASA may actually work a little bit better. I mean, these are soft guidances, if you want to call them, because we don't have prospective data to support these kinds of interventions. But it does help in the case of a relapse patient and try to figure out which agent to pick. I wish we would have more standardized ways to look for these mutations, which we don't at the moment.
Yeah, we do. We use neogenomics, but I agree with Dr. Jain and Dr. Iyer. There are no clear guidelines, but we still use it, especially in the relapse setting, because when patients get chemotherapy first, they develop new mutations that we can target in the future, and also we use it as a form of MRD as well.